Hello, everyone. We are now talking about immunology and infections. So here is our objectives. So first of all, for our body, there are three different defense mechanisms. There's natural barriers, which is your first line of defense. The inflammatory response, which we talked a lot about throughout the semester, that's your second line of defense. And immunity, and this can be acquired, and that is your third line of defense. So the first line of defense is physical and mechanical barriers. So first line of defense is your skin, basically. It is tightly weaved epithelial cells, so nothing can get into your body inside unless it's through a mucous membrane. So, but there are some things that will be absorbed by the skin, so you always have to remember that too. So it's not foolproof, um, but it is our first line of defense. So then if you have a break in the skin, you have a mechanism for bacteria or other infectious diseases to enter the body. You have membranous sheet lining of your different body systems, and those help protect against infectious disease. You have your mucosal epithelial cells that give off mucus to block and kind of trap the infectious or infection agents so that your body can get rid of it. You do have turnover of cells and sloughing of bacteria and viruses. So on our skin, we have a lot of bacteria that lives on our skin. We actually need some of that bacteria for different processes in the human body. So we like to keep that as what we call happy bacteria, nothing that's going to cause disease. But if you have immune compromised person, or maybe you have a break in the skin or something like that, then that happy bacteria can kind of take over and cause an infection. We have cilia movement. So cilia is located in different places in our body. Cilia are kind of like projection of hair from cells, and it moves in kind of a wave to move things along in your body. You have that in your respiratory tract, like your nose, you have it down your respiratory tract, and that just keeps moving things away from the body. The low temperature in our skin is good because that keeps it at a temperature that bacteria, viruses, other infectious agents don't like to grow on. So that is good. And also the low pH of our skin and our stomach help break down some of those infectious agents. We do have biochemical barriers such as mucus, where you talked about that, gets the infectious agent is plugged in there, and then we sneeze, blow our nose, or, you know, vomit or whatever, and it comes out of our body. Perspiration, so sweating actually has an antibacterial and antifungal agent or lysozymes, and those lysozymes break down different bacteria and other infectious agents. Saliva also contains lysozymes, and these attach to the cell wall of gram-positive bacteria. Tears also have lysozymes, so they help protect your eye. Earwax or cerumen, that also is very, very, very sticky, so things get trapped in that, and it comes out your ears. The thing with cerumen is the lining of your ear is constantly moving outward. So as the cerumen collects in the ear canal, it will slowly move outward. That's why we don't want to put anything in our ear to push it back the other way. It will eventually come out on its own. Lungs have collectins, which are surfactants plus binding lectins, and they recognize bacteria and then they release macrophages to engulf the bacteria. Hold on a second. So another thing is we have bacteria that lives on our skin, lives in our mucous membranes, it lives in our GI tract, it lives in your urethra and your vagina. And these keep a steady state of healthy or healthful bacteria. They don't cause any disease unless you're immunocompromised and things kind of get out of whack. But that is called your normal microbiome, and you want that. Now, if you think about a newborn when they're first born, all of these areas are sterile. They don't have any bacteria, but they will colonize very quickly with bacteria after they were born. Commensal means that bacteria, they live together, they benefit, or I'm sorry, they receive the benefit from one organism without affecting the other. So some of the organisms that live in your body, they really don't help us, but they don't really hurt us either. Staph is one of them. Staph, loves to live on your body. Quite common bacteria, and it doesn't really affect you unless you have an injury or immunocompromised. There's mutualistic. This benefits both organisms. So for us, we have several bacteria that live in our gut. They help digest fatty acids. They digest large polysaccharides and other dietary substances. They also produce biotin and vitamin K in your gut. And they assist in the absorption of iron, especially calcium, iron, and magnesium. And also in your colon, they produce chemicals and toxic proteins to inhibit colonization of pathogens. So they keep that kind of steady state, steady number of bacteria in your gut so that it is not overwhelmed with bacteria. If you take antibiotics to kill a certain infectious bacteria or infectious agent, then it can also kill off normal flora or the normal microbiome, and that can cause disease to form. So one of those is Clostridium difficile, which I gave you a website to look for information. We'll go over it in just a moment. But Clostridium difficile causes pseudomembranous colitis, and it can lead to death. Lactobacillus, this protects the UTI and vaginal and vagina from infections. A lot of people will eat yogurt to get lactobacillus. Pseudomonas aeruginosa is on your skin, and that protects against the staph getting overzealous and taking over. So Clostridium difficile, it is a bacteria, but it forms spores, and it's very, very hard to kill it. So it lives on surfaces for a long, long period of time. So a lot of people, well, I shouldn't say a lot, but there's many people that come into healthcare facilities like hospitals or long-term care facilities, and they get C. diff because of the environment wasn't cleaned very well and because it lives on those surfaces. It is resistant to alcohol-based cleaners, so you have to wash your hands with soap and water. If you use the hand sanitizer, it doesn't kill it. So another reason it's very, very hard to get rid of. What the problem with it is it causes pseudomembranous colitis. So in this picture here, this is a scope in the gut, and you can see this whitish material. It is creating a membrane on the inside of the colon. And because you have this membrane, you cannot absorb nutrients. And so you can't absorb nutrients, you can't absorb vitamins, you can't absorb a lot of things. And it will start to irritate the gut, cause erosion, and then even cause the gut to perforate. And then you have peritonitis. So it is very, very serious. And so we want to give it antibiotics. The antibiotic of choice usually is Flagyl that we give. So, and you usually have to take it for a prolonged period of time. Usually the problem when you get C. diff is that you've taken an antibiotic, you've killed off the good bacteria, and now C. diff has kind of taken over. Once you have C. diff, it is very hard to get rid of. So you do want to make sure that you try to colonize the gut with good bacteria. So they'll tell you to eat like yogurt and things like that to help reestablish a good colony in your gut. Over time, like I said, if it's not treated, it can lead to death. And many people get reinfected with it because once you have it, it's very hard to get rid of. So our second line of defense is your inflammatory response. And we've talked about this a bit before. It is rapid and interactive of the humoral system and cellular systems. And it occurs in vascularized tissue because those mediators will get to the tissue through the blood. It's activated rapidly. What happens to the tissue depends on the cellular and chemical components, but it is non-specific. So it could cause inflammatory response to healthy tissue, which we don't want, but that can happen as well. You can have the vascular response. We've talked about this before, where you have vasodilation that increases blood flow to the injury, that increases vascular permeability. So you have blood kind of the white blood cells and the red blood cells kind of leaking out. So that can cause redness to the site. So increase blood flow. Edema is fluid leaking out. Exudate is those white blood cells and macrophages coming to the site to engulf any infectious agents. And it makes that kind of yellowy fluid. Biochemical mediators, we've talked about these. There's histamine, bradykinin, leukotrienes, prostaglandins, and they create spaces on the white blood cells so that they can get create spaces on the vasculature so the white blood cells can get to the site of infection. Also, you could have diabetes and and white blood cells adhere to the inner wall of the vessels to help protect against bacteria or other infectious agents. So some of the benefits of inflammation are it's a prevention um, of infection. It dilutes toxins. Some bacteria will give off toxins. It activates the plasma protein system to destroy pathogens. It's we have an influx of cells, neutrophils, and macrophages again to destroy those pathogens. And limitation and control of the inflammatory process is through plasma proteins, plasma enzymes, and cells that prevent inflammation from attacking healthy tissue. Now, we do have some disease processes that the inflammatory process is not in good check, and therefore the whole body becomes inflamed and you have an inflammatory response you don't want. It does interact with components of the adaptive immune system to enable more specific response. And it prepares the tissue for healing by removing bacterial products, dead cells, and products of inflammation. We have the extravascular fluid and debris is removed per the lymph system. So this can cause your lymph nodes to become enlarged, hyperplastic, or large cells, and very painful. Remember that things drain in the lymph system towards the heart. So if you have an enlarged lymph node, let's say in your neck, where the problem is above that or in that area. So maybe an ear infection or a throat infection, or I've seen them before from um, like lice, a really bad case of lice. If the scalp becomes inflamed with lice, you can have enlarged lymph nodes in your throat. If you have enlarged lymph nodes in your axilla, that's coming from your arm. So there's something along the arm that's causing that. So just keep that in mind that everything's draining towards the heart. So if you see an enlarged lymph node in just one particular area, you're going to look distal to see where that's coming from. Now, if you have a lot of enlarged lymph nodes, that's more of a systemic problem. And it's not just one particular area, such as like mononucleosis. We also have the plasma protein systems. We have the complement system, the clotting system, the kinin system. And these consist of proteins in the blood and they're usually in an active state, and then activation of the system starts a cascade. So the complement system destroys pathogens directly. We have the classic pathway where activation of the protein of the adaptive immune system binds to the target. This is an antibody antigen response. So the antigen comes into the body, it binds to the antibody, and then you have this classic pathway where you have a response and you make all these antibodies against it. And because of that, they are there for the next infection. So this is adaptive immunity because it adapts so that, it's just if you think about like immunizations, when you get the immunization, you're getting a part of an antigen, not the true antigen, but a part. So maybe it's altered or maybe it's dead and they inject that into you, but it still causes that antibody to form. And then you have the antibodies. So when that antigen comes back and tries to invade the body, the the antibody will be there and it will block it so that you don't get sick. The lectin pathway is activated by mannose-containing bacteria, bacterial carbohydrates. Again, it is going to kill those bacteria. And then there is an alternate pathway. This is activated by gram-negative bacteria or fungal cell wall polysaccharides. So we've talked about the coag cascade or the clotting cascade. Again, you don't have to memorize all of this. It just can kind of see again how we get basically a clot to form. And because of this, it prevents the spread of infection to other tissues. So that clot forms, that framework is there so that the microorganism can't move, it's trapped. It forms that clot to stop any bleeding or leakage from the vessel. And it provides a framework then with the fibrin. And so that it can recover the tissue. You see that there's lots of different factors that are required for that. If you go into hematology, of course, you'll need to know this, but most people don't. But it is quite the cascade. And whenever you have a patient who has a bleeding disorder, it's usually something wrong with the cascade. They usually have some kind of enzyme they're missing or factor. The Kine system is, it usually produces bradykinin. That's the main one. It dilates the blood vessels. It acts with prostaglandins to stimulate nerves to produce pain. So you know that something's wrong. It causes smooth muscle contractions. It increases vascular permeability and increases leukocyte chemotaxis. Chemotaxis means that you're moving something in the body, some kind of movement. So this is movement of the leukocytes to the infectious sites. So that's what bradykinins do. They allow the blood vessels to dilate, then produces pain, contracts, and then permeability so that those leukocytes can get to the infectious site. We have a cellular response, that's the cytokines. We've talked about them before. This causes intracellular signaling that binds to receptors and regulates innate and adaptive immunity. So we've talked about adaptive immunity where the body is introduced to the infectious agent and then it creates immunoglobulins and also antibodies to protect against it happening again. Cytokines are pro-inflammatory, which mean they induce inflammation, but they're also anti-inflammatory where they inhibit inflammation. So it is a feedback loop that that way the body is not overwhelmed with inflammation. Pleiotropic, they're pleiotropic. Some molecules have different functions, and based on what it binds to, it has different functions in that cellular response. Some are synergistic, which means that if they combine, they exceed the individual activity. So if you have something that's sort of working, something else is sort of working, you put them together, it's more than twofold helpful. And then there's antagonistic, which they inhibit each other. So interleukins are messengers produced by macrophages and lymphocytes, and they adhere or they alter the adhesion molecule expression in the cells. So they attract leukocytes to that site. They induce proliferation and maturation of leukocytes in the bone marrow. And they generally enhance or suppress inflammation. So they're sort of like the cytokinins where they, if it's needed, they're activated. If it's not, then they decrease the activation. And they have the mediation of development of acquired immune system. So there's a couple different infectious ways. Well, I shouldn't say infectious, but how the body reacts to different things. So there's autoimmunity, and this is caused by genetics. So it may mean that you are immune to a particular disease when other people are not. It just gives you a different susceptibility to the disease, and that is genetic based. And that affects the specific target tissues and cells, and you develop a tolerance or protection from the immune response to your own cells. Alloimmunity means that the individual immune system reacts to antigens or tissues from other members of the same species. So we usually see this in the mother and fetus. ABO incompatibility is one. If the mother's blood type is O or she's Rh negative, or there's anti-D, anti-E, other things that will affect the baby's blood type. So it will cause antibodies to form against it, and those antibodies then will break down the baby's blood type. So there are some hypersensitive diseases that the mom's disease process will affect the fetus. So in Graves' disease, if mom has Graves' disease during pregnancy, it can cause neonatal hyperthyroidism. Myasthenia gravis, it can cause neonatal muscular weakness. Immune thrombocytopenic purpura, or ITP, causes severe neonatal thrombocytopenia. Autoimmune neutropenia causes neonatal neutropenia. Systemic lupus erythematous induces anomalies or birth defects or even a fetal loss. And then we just talked about the Rh-ABO alloimmunization, which is probably the most common one that we see, and that causes breakdown of the fetus's blood cells. And so you have neonatal anemia and elevated bilirubin levels because bilirubin is a byproduct of the breakdown of red blood cells. A gnat around here. So some of the cells we see in our immune response are the mast cells. They are cellular bags of granules, gosh, yeah, granules, and they're located in loose connective tissue close to the blood vessels, the body's outer surfaces. When they're activated, or they are activated by physical injury, chemical agents, so they give off histamines, they give off cytokinins. We talked about this a little bit before. They also produce heparin, and also immunological means. Basophils, they function the same as mast cells. They're regulated by degranulation, which releases the contents of the mast cells, and then synthesis creates production and release of mediators. So phagocytes are a type of neutrophil. So there's different types of neutrophils. Neutrophils are mature white blood cells. They're short-lived, they're destroyed easily, and they mix in with pus. Eosinophils we talked about before. You see them with parasitic infections. They regulate the vascular mediators released from mast cells, and you will see them in allergies as well. Basophils are associated with allergies and asthma. Dendritic cells are located in the organs and skin, and they migrate through the lymph system to phagocyte or eat pathogens. And monocytes are your immature macrophages. So for wound healing, there's a couple phases. There's phase one where it's the inflammatory response. So increased permeability of the vasculature. So you have serous fluid leaking out, you have the white blood cells coming out. The area becomes red because you have more vasculature and vasodilation to get more blood flow to the area. So you have edema, you have pain, which we just talked about. So that is your body's first reaction. Then it goes into phase two, which once starts the healing process, you have proliferation and new tissue formation. This typically occurs 3 to 4 days after your injury, and removal of the eschar. So eschar is basically the scab. Eschar is just dried up serous fluid, macrophages, white blood cells that are covering the injured area. It becomes very dry, and then once the skin underneath is healing, then it falls off. And it's not normal tissue yet. You'll see it's kind of still pretty red, but it is healing. During this time, you'll have secretion of biochemical mediators, and they transform growth factor beta. You have angiogenesis factors, so more vasculature to the new tissue. Matrix metal proteinases also breaking down some of the structure or the framework. All right, so adaptive immunity. Some of the products from adaptive immunity, which we talked about earlier, is antibodies or immunoglobulins. They're the same thing. So immunoglobulins are antibodies, and lymphocytes for particular antigens. So for lymphocytes, you have T lymphocytes and B lymphocytes. In the fetus, you have differentiation and proliferation in the thymus and the bone marrow that creates stem cells, and those stem cells then create the T lymphocytes and B lymphocytes. And these develop on cell surfaces of the antigen receptors. So we have active and passive immunity, and this gentleman here is Dr. Henry Jones. I think he is finally retired from Indiana University in Indianapolis. He came when I was a student in my nurse practitioner class. He came and talked to us about vaccines, active and passive immunity. And I'm telling you, he was just fabulous. I wish he would still talk, because after his talk, I like won every vaccine available, because it's amazing. Just some of the things he's talked about that the human body has to fight off. And anyways, so this is my homage to Dr. Jones. Like I said, I still remember his name. He was that powerful of a speaker. Anyways, so we have active, and that's where we make our own T cells or antibodies in response to an antigen or after immunization. So if we get the immunization, the antigen is there, but it's manipulated, so it doesn't cause us to be sick, but we still create the antibody or the T cells. If we get sick on certain bacteria or certain viruses, we create our own antibodies, so the next time we may not get as sick, or may not get it at all. So like if you got chickenpox as a kid, you don't get chickenpox later on. And these are lifelong. If it's an immunization, you may need boosters. It depends on which immunization you're getting. Some of the boosters that we get now, we didn't have boosters like, I remember when I got shots for pertussis, they were like, it's lifelong. And then I can't remember how old it was. I mean, I was older. early in my 30s, and they were saying, it's not lifelong. You have to get a booster. So now we get boosters of pertussis. So sometimes when you get those immunizations, it's not lifelong. You do need a few boosters. Some of them, though, are lifelong. Like hepatitis B, once you get the 3-dose series, you don't need a booster anymore. Hepatitis A is the same way. Passive means that you are receiving the antibodies or those T cells from a recipient. So someone else has made those T cells, antibodies, and then they give them to you. These do come from the blood. They are considered a blood product. So you must have a consent before giving these. Some are specific and maybe generalized. IVIG is a very generalized form of this kind of passive immunity. It can be from mother to fetus, so mom passes on this immunity to the baby, and then they are protected, but usually it's only about a month. So these do not last very long. They are not, so like RSV, now we have a vaccine, used to be a immunoglobulin that we would give, and the children would have to get it every month during RSV season. Um, so, that's just, you know, the drawback of this, but it does work pretty well. So again, the antigen is a molecule that reacts to the binding sites on antibodies or antigen receptors on the B and T cells. Immunogens, they induce an immune response, and that's result in the production of the antibodies. So when you're making antibodies, you also create that immune response. The antibody is an immunoglobulin. It's a glycoprotein binding, and it produced by plasma cells a response to the antigen or I'll just say pathogen. Antigen to antibody, and then the immunogen to immunoglobulin. So if you're looking at these antibodies, there's different kinds, and they mean different things. So if you order labs and you order these antibodies, you have to know what they're showing you. Um, so IgG is your most abundant antibody. It is most protectant activity against infections. It can cross the placenta, so the mom can give it to the baby, and that usually lasts for 6 months of protection for the baby. IgG is usually the one that we give for in hospitals just to protect against this antibody antigen process. IgA is the antibody found in normal body secretions, usually in the mucosal cells, and this protects the tissue from degradation. So it is not particularly something that you get after you have been exposed to an antigen. It's just something that's there to protect your tissues. IgM is the first antibody produced during initial exposure to an antigen. And this will increase during exposure to infection in utero. So, if you want to know if they have protection against a particular disease, and you do an IgM and you do an IgG will tell you if they have protection. IgM will tell you if they're infected now and or if they have an active disease process or had one recently. So IgG, let's say, we do this for our babies. We draw IgM, IgG, and it comes back and it says, IgG is elevated for, I don't know, herpes or something like that. IgM is low. That means that they got the antibodies from mom. They've never had the disease. Those IgG antibodies are going to go away eventually. Like I said, they don't last very long, a month to 6 months. And so the child's protected now, but later on, may not be protected. If you see an elevated IgM, that means that they've been exposed recently or they've had the disease recently. So just know the difference between the two. IgD, very low concentrations. This is an antigen receptor on the surface of the B lymphocytes. Ig, this is what you see in allergic reactions or defense against parasites. So know the difference between all the immunoglobulins, because when you draw that blood work, you need to know what it is telling you. So it's very important that you understand the difference in all of them. All right, infections. So there's several infectious agents in humans. There's bacterial, there's fungal, there's protozoan, there's helminths, and viruses. And there are other ones too, but these are your most common, although helminths and protozoans don't see quite as much, but they're still out there. This is a nice case of ringworm. Ringworm is actually a fungus. It's not a worm. It's not a parasite. So infectious bacteria is caused by true bacteria. So that's either cocci, bacillus, vibrios, or spirilla. You can have filamentous bacteria that have branching or mycelium structures, and they resemble a fungi, but they're not treated like a fungi. They're not a fungi, so the treatment for fungi should not be used. And we call those mycobacteria. You can have sphericets, and these are spiral filaments. They are motile and anaerobic, so don't need oxygen to grow. You can have mycoplasmas, which are very small. They're rigid cell walls. Rickettsia are intracellular parasites that can be rod-shaped, spherical, or pleomorphic. And then there's chlamydia, which is intracellular parasites with complex intracellular life cycles. So all of these, if it's a bacteria, it's treated with antibiotics. We may have to treat with multiple antibiotics depending on the type of disease process it is. Or we don't know what bacteria is causing it. We just know it's a bacterial infection. So we start with broad spectrum. The problem with this, with the broad spectrum antibiotics, is a couple of things. First of all, using a lot of broad spectrum antibiotics can actually cause drug resistance in drugs. So we have to have that, make sure that we are being cognizant of the antibiotics we are prescribing. And also, it can kill off your happy bacteria too. So those big gun antibiotics can really kill off your gut bacteria, and then you're at risk for like C. diff or those kind of things. So it's not, we do want to stop the infection, but we really need to find out what kind of infection it is. One of the things that is interesting, I always see one of the DNP students a couple years ago did a project on the use of antibiotics in upper respiratory infections. And I see this to this day because people ask me, like, oh, I've got bronchitis, I'm coughing a lot, I want azithromycin. Azithromycin is not the drug of choice for upper respiratory infections, but I see it prescribed a lot. So it's really important to follow the guidelines from the CDC or other reputable sources on what antibiotics should be prescribed for possible infections, because we don't want resistance to happen, and we don't want to kill off any good bacteria in your patient's bodies. Fungi. There's several different kinds. We have histoplasmosis. Histoplasmosis you usually see in the soil around birds or bats. So if people have chickens, it's kind of a uptick in people having chickens, and they don't realize that chickens, hold on a second. Or pardon me. Chickens, their feces can carry histoplasmosis, and you get pretty sick with histoplasmosis. It can cause a lung infection or around bats. So if you go spelunking out in the caves with the bats, then you are at risk for this as well. Um, when I was in my undergrad, so well, that was a long time ago, I took a fungi course, and we had to go around to people's bird feeders, and we dug up the ground underneath their bird feeders, and we found that the soil around a bird feeder that's been there for a long period of time had more histoplasmosis. So again, that's another thing you might want to watch too. Might be a good history question for somebody if you think they have a lung infection. Ask them if they have lots of bird feeders or they have chickens or other kind of birds. Or they go spelunking out in the caves. Canada is yeast. Yeast likes moisture, it likes sweetness, it likes darkness. So you can imagine where it loves to go in the body. Very difficult to treat if it gets inside of the body. Outside on the skin, not as difficult to treat, but inside is very difficult to treat. Coccidio domycosis is also in the soil. It causes lung infections. Dermatophytes, that's your basic ringworm. So ringworm, like I said, is not a worm. It is a fungal infection. They can be difficult to treat. Now, skin infections with like Candida skin infection, ringworm, those are fairly easy to treat. It's an antifungal that you're using and fairly good to treat. The problem with antifungals is you have to use them for extended period of time. People get better, so they stop using it, and then it just comes back. The problem with fungi is they have spores, or they have like here, this is yeast down here on the lower side. This is histoplasmosis above there. And you can see like it has these little buds that break off. And then and if you don't do the antifungal for a prolonged period of time, then it just comes back with a vengeance. So that's one problem for like skin infections. If you get like yeast sepsis, Candida sepsis is almost impossible to treat. It's very, very difficult to treat because it encapsulates itself. So it attaches to vessel walls. It can attach in the brain, in the ventricles. It can attach in the heart, in the ventricles, and encapsulate itself. And it just is like clinging to the tissue. And you'll see it on like an ultrasound or something or a CAT scan. And it almost like umbilicates itself so it could break off and cause an emboli very easily. Like I said, so hard to treat. Oh my gosh, if you get someone with yeast sepsis, it's a long road. It's a long road. It's a long time on the antifungal IV medication. It could be a chronic problem, especially if you have a weakened immune system. You can get multiple infections. Yeast tends to kind of spread throughout the body. People with diabetes tend to get yeast because it likes sweetness. So, and its skin folds because it's dark there, it's moist. Yeah. And you think you got it under control and boom, it pops out somewhere else. So it can be a chronic issue. It's the same with like ringworm, if you keep getting exposed to it, you may treat one person, but maybe someone else in the family has it. So you want to treat everybody in the family. It can be a problem. And all of them are treated with antifungals. Antifungal IV medication not always uh, does well on some of the body organs. So again, it's tough. It's tough to treat some of these. Parasites and helminth, God, that's hard. And protozoa. They adhere to and break down connective tissue. They release enzymes, proteases, and phospholipidases. Anything with aces on the end means it's breaking it down. So it's breaking down proteins, it's breaking down phospholipids. Remember, phospholipids make up the cell wall, so it's damaging the cell wall. So you have extensive tissue damage through exacerbated inflammation and then that immune hypersensitivity reaction. More common in immunocompromised people. Most of us can fight off some of these and it doesn't become a huge issue. You have malaria we get from mosquito bites because they carry the malaria, gardasiosis, and toxoplasmosis. Um, these can be treated with antibiotics. Sometimes antibiotics will take care of them. Or there's other medications such as metronidazole, which is Flagyl, or quinine. So, I don't know if you've ever taken Flagyl. I got C. diff many years ago and I had to take it. And like, no wonder these people with STIs don't take it. It tastes terrible, but it's better than having the infection, right? So there are different kind of treatments for those. Viruses destroy our damaged cells, and they're part of a replication of infected cells. Viruses can't really live on their own. They have to have a host to live. So there's always this discussion, are they a living thing or not? But anyways, we won't get into that. But they have a life cycle. So the virus will attach to the cell wall and it penetrates the cell wall by endocytosis or membrane fusion. And then it releases its DNA material into the cell. And then the cell will replicate that and make more viruses. And you have a whole bunch of virins, a whole bunch of them. And then there's so many that the cell ruptures and then more viruses are released. And they can be released through lysis, which is breaking down the cell wall, or budding, coming out of the cell wall. Viruses are obviously treated with antivirals. They're a little bit harder to treat. We don't always have an antiviral medication for every virus out there. The thing with viruses, they tend to morph, so they tend to change shape. So some of the antivirals don't work as well. So for instance, influenza, it changes its shape. That's why every year you get a different influenza shot. So it protects you against some viruses, some influenza viruses, but it doesn't protect you against all because they mutate. Or retroviruses. Retroviruses are like that. So influenza is a retrovirus. HIV is another retrovirus, so it changes shape, and so it's hard to treat. So usually with HIV, there's such better treatments with HIV now. But used to be you had to take many different antiviral medications because it is a retrovirus. So that's why they're very difficult to treat because they keep changing shape or the way they act in the body. I think, yep, that's all we have. So if you have any questions, let me know and have a good week.